Well, thank you to MS Views and News for inviting me out here to speak to you all today. I'm going to talk about MS, NMOSD, and MOGAD. And here's a little outline of what we'll be talking about. So from an MS standpoint, I'm going to talk briefly about some of the latest treatments that are available. Then we're going to review NMOSD and MOGAD. There's a lot of overlap, and when I'm reviewing that, I'm also going to talk a lot about how it compares with multiple sclerosis, because a lot of those of you who have been diagnosed with NMOSD or MOGAD, the most common misdiagnosis is going to be multiple sclerosis. And then we'll talk about some of the optic issues unique to these three autoimmune central nervous system disorders. Right now, we have over 20 different MS treatments. And if you look at the landscape of treatments and where they kind of started out, you think about that first treatment in 1993 compared to what we have available now, especially the last 10 years or so, there's been an explosion in disease-modifying treatments for multiple sclerosis. And they vary in terms of administration, convenience, side effects, that sort of thing. So we have injections. Those were the first treatments that came out in the 90s. Oral treatments, and then infusions. So infusions are where you go into an infusion center and is administered through an IV, compared to an injection where you would administer it yourself at home. Historically, we used to have conversations with patients and we would kind of say, these injections, they are maybe not the strongest, but they have a more favorable safety profile. Whereas the infusions, these are our drugs that work really well. They're very strong, but they require a little bit more monitoring. And then with the orals maybe being in the middle of the road. But as we continue to develop more and more drugs, that does not hold true the same anymore. We have drugs that are highly effective that maybe don't cause as many problems or side effects as other drugs that don't work quite as well. So it's a highly individualized process where we're determining what drug a person should be on. So here I have listed some of the treatments that have come out in the past 5 years. So I'm going to go backwards. So the newest treatment is Ocrevus Zunovo. Has anyone heard of that one yet? Go ahead and raise your hand. Okay, so this is a subcutaneous Ocrevus. The intravenous Ocrevus was FDA approved in 2017. It was FDA approved for relapsing remitting MS and primary progressive MS. And that was really important because it is, or was, and still is, the only FDA approved treatment that we have for primary progressive MS. So this subcutaneous form now of Ocrevus, or ocrelizumab, has the same indications as its IV form. So it's still FDA approved for relapsing remitting and primary progressive MS. But the route of administration is different. So it's every 6 months, but rather than going in through an IV, it's subcutaneous. Now, it's not the subcutaneous that you think of with other injections that we've used for MS. This injection does have to be administered in the clinic, in the office, and it's not just a auto-injector, bam, you're done kind of injection. It's a slow injection, takes about 10 to 15 minutes, okay? And it's going into the belly. All right. So it's freshly kind of FDA approved. I know at our center, we're not quite giving it yet. We will be. So that's something that if you had interested in, you could talk with your neurologist about it. Next thing I want to talk about is natalizumab, the biosimilar. So the brand name for that is going to be Tyruko. Biosimilars. So biosimilars, and for those of you who have ever been on Rituxan, for example, may be familiar with biosimilars. Like the name implies, it's a biologic that is very similar to the drug, but not identical to. So when it's approved, the FDA wants to make sure that that drug works as well as the one that it's supposed to be similar to and has a similar safety and side effect profile. So this is the biosimilar for Tysabri. Tysabri was originally FDA approved for multiple sclerosis in 2004. And it's important to know about it for those of you who are on this drug. As this biosimilar, if it becomes more readily available, there may be insurance mandates to where they have a preference for one or the other. Next is ublituximab. The brand name for that is Briumvi. This was FDA approved in 2022, December 2022, so 2 years old at this point. This drug is very similar to our other B-cell depleters, monoclonal antibodies against CD20. So those are going to be things like rituximab, ocrelizumab, which we've already been using in the MS arena. Works the same way in terms of depleting those B cells. It's given similarly. It's an IV infusion every 6 months. And so then you ask yourself, well, what's the difference, right? The design of the molecule is slightly different. And I think that's important because if ever you're considering a switch between that class of medications, there is a chance that it may work different for somebody. And then ofatumumab. Ofatumumab goes by the brand name of Kesimpta. Kesimpta is also a B-cell depleter. It works against that antibody, a CD20. That's, again, similar to our ocrelizumab and our ublituximab. The difference here is going to be, rather than getting an infusion every 6 months, it is a self-administered subcutaneous injection once a month. And then lastly is cladribine. So cladribine was FDA approved in 2019. And we found that a lot of our drugs that came out 2019, 2020 were kind of a slow roll a little bit because of the pandemic. A lot of neuroimmunologists and MS specialists were having a little bit of caution in terms of using new or different medications. But cladribine goes by the brand name of Mavenclad. And this is a different kind of medication than the ones we've talked about so far. Most MS medications, when we tell you to start them, we say, okay, take this until we don't know when, right? It's indefinite. Cladribine is what we call non-continuous immunosuppressive therapy. So you take the drug intermittently over 2 years, and then you don't retreat for most people, okay? More recently, there is an option, depending on the needs of the patient and the concerns of the neurologist, to offer another course of treatment after 4 years. But most of the data we have is after the initial 2-year course of treatment. And again, you kind of think of it as a little bit of an immune reset. So a different type of treatment than what we have available otherwise at this time. So what do we still need, right, for our MS patients? We need options for progressive disease. And when I say progressive disease, I mean primary progressive disease. As I've already talked about, we only have one FDA-approved treatment right now. We need options for secondary progressive disease. There's all these terms now. So we talk about PIRA, so progression independent of relapse activity. A lot of MS patients, and I'm sure a lot of you can relate, you come into us and you're saying, I'm not feeling good, things are getting worse. And we're like, yeah, but your MRI looks the same. We're not seeing any change, right? So what is behind that? What's causing that progression without any objective evidence that we can really find? And how do we treat that, more importantly? We don't have good options for that right now. We also need options for remyelination and regeneration. Again, I know we definitely want a cure for MS. That would be awesome. But for those of you who are already living with disability related to MS, how can we restore that function? How can we, get maybe the walking speed better, the vision better, all of those things? How do we do that? Again, we don't have good options for that. And then biomarkers. We talked about having progression and not really having a way to objectively measure that or prove that it is or is not present. So having certain tests that we can look at to measure and tell us what's going on to help us make decisions with regard to treatment, those are also needed. And then briefly, we're looking a lot at non-pharmacological approaches. Especially with relapsing MS, we've become quite good at being able to shut down disease activity, stopping new lesions, stopping new symptoms, stopping relapses. So now we're really focusing on other areas of need, kind of looking at the whole patient. So dietary interventions, what we've learned is that they may help in reducing inflammation and supporting brain health. We've been looking a lot at cognition. So depression and anxiety are incredibly common. And what they find is that cognitive behavioral therapy can help and manage some of those psychological aspects of disease. Mindfulness and stress reduction techniques can improve mental well-being, overall well-being. And then exercise, a lot of benefits from exercise. And so there's a lot of data and research to show that it can improve mobility, improve fatigue, energy levels, and enhance overall quality of life. All right, so now we're going to move on and talk about NMOSD and MOGAD. So these are both considered rare disease. And as I was getting ready to do this talk, I had to Google it because I was like, what exactly makes it a rare disease? And it's less than 200,000. If it's less than 200,000 people that are living with that disease in the United States, they consider it rare disease. But what I'll say is with both of these, we really don't have an accurate number of people, it's going to be really, the numbers really lowballing what it truly is. And that's because the rate of misdiagnosis is so high. And so we have a lot of work to do in that regard. So first, NMOSD stands for neuromyelitis optica spectrum disorder. Okay. And if you look at the name, it tells you a lot about how the disease behaves. So myelitis, meaning inflammation of the spinal cord, and optica, the optic nerves. So those are kind of two of those hallmark symptoms. So you see very predominant optic nerve and spinal cord inflammation with NMOSD. So what causes it? There is the immune system that's abnormally attacking proteins in the central nervous system. And as we heard earlier, that aquaporin P4, AQP4, this is a protein that's expressed on brain cells called astrocytes that are only found in this, central nervous system cells, only found in that area that cause inflammation and damage. And so again, there's an actual antibody here that you can measure that can tell you whether that disease is present. Hallmark features, again, that optic neuritis. Here, the optic neuritis, again, that inflammation of the optic nerve. And just so you know, again, the optic nerve is going to be the nerve that connects your eyeball to your brain, and it can become inflamed anywhere along that pathway. With NMOSD, it can oftentimes affect both eyes at the exact same time, or what we call rapidly sequential, where it's one eye and then the other eye soon after. That would be atypical for what we typically, for what we see with multiple sclerosis, where it's usually one eye. The transverse myelitis, meaning that inflammation of the spinal cord, usually that presents a little differently as well. I'll say a little bit more dramatically, to be honest, but you get inflammation of the spinal cord that tends to cause symmetric, so weakness that's affecting both lower legs, both arms. The reason for that is the inflammation is so widespread that it gets the entire diameter of that spinal cord, whereas with multiple sclerosis, sometimes those lesions are a little smaller or located on one side, so you may have weakness that's only affecting one side of the body. We tend to see a lot of bladder dysfunction. That can be difficulty holding urine in or getting it out. Sometimes we'll see a sensory level. And again, this isn't unique to NMOSD, but just having an area of numbness that just kind of maybe sits at one part of the chest, for example, would really suggest that there's something going on in the spinal cord. Tonic spasms, so that's when almost like a very dramatic Charlie horse in a part of your body where the muscles just kind of lock up and remain very painful. Okay, that's a little bit more common in NMOSD as well. Radicular pain. I would compare that most to if anyone's had a pinched nerve before and you get a pain that's kind of maybe shooting down the arm or leg. And again, the reason for that is the inflammation is more widespread, so it actually spreads from the spinal cord to where the nerve roots come out to innervate the extremities. So you can get these electrical pains. And then Lhermitte sign. Again, not unique to NMOSD, but if there's inflammation high in the neck and you just put the chin to the chest, that's enough pressure sometimes to cause an electrical sensation throughout the body. So these are some of the symptoms that we can see with NMOSD. Other features, so brain features can happen as well. These probably did not get as much credit early on, which is why they just called it NMO at first, neuromyelitis optica. Later on, they added that spectrum disorder because it is a spectrum and you can get these brain features. So the intractable nausea, vomiting, and hiccups, the name for that is area postrema syndrome. And we do see that. And that's because that AQP4 that we talked about, one of those areas where it's highly expressed is the kind of nausea, vomiting center of the brain. That's a very odd presentation, though, to have for your first NMO attack, because you can imagine if you show up to the ER or your doctor and you have nausea and vomiting, they're probably going to treat you as you have some sort of stomach bug. So it promotes that misdiagnosis. You can get brainstem syndrome. So the brainstem is the part of the brain that basically connects the spinal cord to the larger part of the brain. It's where a lot of our cranial nerves live that control swallowing, speech, facial sensation, how our eyes move. That can be involved. Fulminant cerebral demyelination. That basically means you can get very rapid onset and severe inflammation within the brain. We also see uniquely, we don't see this much with multiple sclerosis, is hypothalamic dysfunction. The hypothalamus in the brain is the part that controls like temperature regulation, sleep, wakefulness, endocrine function, when we think about our pituitary hormones, thyroid, that sort of thing. And that's why as you look through the different criteria for NMOSD, they talk about narcolepsy, because there are individuals that will present with some of those symptoms to include disorders of wakefulness. So that was NMOSD. Now we're going to talk about MOGAD, and I'm going to say myelin oligodendrocyte glycoprotein antibody associated disease one time, and then I'm going to say MOGAD. Okay. So MOG is the protein that's affected here. So there's antibodies against MOG, and we know that MOG is expressed on the outer surface of the myelin sheath within the central nervous system. And so when there's inflammation there, it can present very similarly to with MS, where the myelin is being destroyed or inflamed. Similar to NMOSD, it affects the optic nerves, brain, and spinal cord. So as you can imagine, both of these disorders present very similarly. Clinical features. So again, optic neuritis, transverse myelitis, same thing. The brainstem encephalitis, you can still get that same nausea, vomiting type of syndrome that I talked about with NMO. One thing that's a little unique here is the brain syndrome, where there's kind of delirium, altered mental status, behavioral changes, seizures. We don't typically see that with NMOSD as much. We don't see that with MS, rarely ever. And so that's something that maybe distinguishes it a little bit more. The clinical course here is unique as well. With NMOSD, we kind of have this approach. It's not if, but when. When will you have that next attack? And we don't want you to have it because of how severe it could be. So over, 95% of people with NMOSD will have another attack within that first 5 years of diagnosis. And as we heard from Ms. Linda, it can happen very, very quickly. With MOGAD, it can be relapsing in about half, and in the other half, it's monophasic, meaning it was a single episode and it's never going to happen again. So for those of us that treat MOGAD, you can understand that if there's only ever been one attack, we're kind of a little unsure of what we want to do. Do we want to put you on lifelong immune therapies for something that was only ever a 50% chance of recurring? Or do we want to watch and wait and run the risk of there being another attack? So we're still definitely trying to learn about prognostic factors and things that can maybe tell us the likelihood of a second attack coming. And the other thing that we see with the clinical course is that it varies between children and adults. So kids with MOGAD tend to have more of the optic neuritis and this this brain syndrome, where they can have a lot of confusion, seizures, behavioral changes. Adults, on the other hand, it tends to look more like the NMO, where it's optic nerves and the spinal cord inflammation. So here are little interesting things about what we know from our demographic information. So with NMOSD, there's an overwhelmingly female preference, so 9-1. If you think about MS, where it's 3 to 4 to 1. 3 or 4 to 1. With MOGAD, it's a 1-to-1, so we're not seeing as much of that gender difference. Age, so with NMOSD, majority between 30 and 50, but I always hate saying this because it's such a widespread distribution. There are we've seen children with NMOSD, and I've seen people in their 70s with their first NMOSD attack, so there's a lot of variance. MOGAD, you kind of see this bimodal distribution, where there's a surge during childhood, so age 5 to 10, and then another one during early adulthood between ages 20 and 45. And then ethnicity. So the majority of people with NMOSD tend to be Black and Asian ancestry, more than white. So that's something that's unique to NMOSD. With MOGAD, we're still learning a lot, and so we don't really have any ethnic differences that we've been able to find. So briefly here, I'm just going to go through each of those kind of symptoms with talking about the optic nerve, the spinal cord, and the brain in terms of some subtle differences and things that we pay attention to when we're evaluating a patient. So again, with both NMOSD and MOGAD, the optic neuritis, the inflammation of that optic nerve, tends to impact both sides, left and right, bilateral. That's the most common. And with both of these conditions, it tends to be a longer segment, so a longer length of that optic nerve. With multiple sclerosis, the segments tend to be very short, so the inflammation is less bad. Looking at NMOSD, when we say posterior involvement, we mean that the inflammation is farther back in the optic nerve, so closer to where that optic nerve connects to the brain. With MOGAD, we tend to see that the inflammation is farther to the front of the optic nerve. So that would be where the optic nerve connects to the eyeball. And that's really important because somebody with NMOSD who goes to the eye doctor and you can't see, they're like telling you it looks fine. I don't see anything wrong. That eyeball, when they dilate your exam and look at the optic disc and nerve head, they'll say it looks fine. Pupil may not respond quite well, but from the fundoscopic exam, otherwise fine. With MOGAD, or when you have the inflammation at the more in the front where that nerve connects to the eyeball, they can see the swelling on that exam. And so that's why it's important to know that sometimes with NMO, you may not see that. All right, next with the spinal cord. So just, I guess from a neuroanatomy standpoint, we tend to, we number our vertebrae. These are numbered by nerve roots, but the spinal cord ends right at the bottom of the thoracic spine, right around T12, which is why your physicians probably don't ever really look at your lumbar spine because there's no spinal cord down there. So we really are focused on the central nervous system, so that spinal cord. And what we see with both NMOSD and MOGAD is that the lesions tend to be a lot longer, okay? We always measure them. We say at least 3 vertebrae or 3 bone lengths long. MS tends to be shorter. Again, there's exceptions to this. There are certainly people with both NMOSD and MOGAD that have short lesions, but these are certain patterns that we keep in mind. With MOGAD, compared to MS and NMOSD, we tend to see that the lesions are going to be farther down in this thoracic area. And even this part is called the conus. It's going to be the most bottomest part of the spinal cord. The conus, that part, that's pretty rare to see lesions with MS there. Not impossible, but uncommon. With NMOSD, we tend to see the lesions farther up. They're going to be in the cervical region and the upper thoracic region. The other thing we see is with the clinical course, with both, they tend to have a very severe onset, but the recovery and disability with NMOSD tends to be more pronounced than what we see with MOGAD. Excuse me, the disability more pronounced, the recovery poor with NMOSD. And then what about the brain syndrome? So these are just some examples, but from the brain involvement, we see, again, when we think about that nausea, vomiting, that area postrema, that's actually the 3rd most common first presentation for NMOSD. So that's something that we think of as the part of a common brain symptom. With MOGAD, I talk about this ADEM-like presentation. Has anyone here heard of ADEM, acute disseminated encephalomyelitis? Okay. It comes up sometimes as you're trying to get to the correct diagnosis. So this is under the same umbrella as everything else we're talking about tonight. It's a central nervous system, autoimmune, inflammatory disorder. It does tend to affect kids more than adults, and it's usually preceded by some sort of infection, a viral or bacterial infection. And it's very widespread inflammation within the brain and sometimes the spinal cord too. But the difference is it's a one-time thing. It's purely kind of like an immune post-viral or post-infectious phenomenon, and then it does not recur. So as you can imagine, someone may be diagnosed with this, and then a year later they have another attack, and then you realize, oh, that was never ADEM, that was MS or NMOSD or MOGAD, that was something else. So again, just comparing the disease course. So with NMOSD, it is relapsing. You're going to, without treatment, we expect that there will be another relapse. With MOGAD, it can be a one-time single episode, or it could be relapsing. The attacks with NMOSD, you have severe attacks, poor recovery. With MOGAD, severe attacks, fairly good recovery. With MOGAD, we actually even see the lesions sometimes disappear completely. It's a very odd thing. But again, in hindsight, when we see that, we could say, oh, maybe that goes more along with MOGAD. With NMOSD, there's no progression in between attacks. And same thing with MOGAD. These are attack-driven diseases. With MS, we do see progression in between attacks. So that's another difference. And then autoantibodies. So for those of you living with MS, there's not one test we can do to say that rules it in or that rules it out. It's definitely a combination of your symptoms, what your MRI shows, if you got a lumbar puncture, what that shows, all of those things, you kind of put it together and make a determination based on that. with both of these, there are antibodies that greatly assist with diagnosis. So with NMOSD, it's these AQP4 antibodies. So if you look at the history of NMOSD, they had the first diagnostic criteria for NMO in 1999. They did not have commercially available testing for that antibody to diagnose NMO until 2004, and then it was incorporated into the updated criteria in 2006. So, 20 years ago, it's not that long ago. Then you look at MOGAD. The MOG antibodies, commercially available to use in testing in 2017, and it was just incorporated into the first iteration of diagnostic criteria in 2023. That was just last year. So this is a very new diagnosis. And what's also interesting is that with both of these, NMOSD and MOGAD, before they were found to be distinct from MS, they were thought to be just variants of multiple sclerosis. And so there are people who, in MOGAD, for example, who were treated for MS, and then when the testing became available, then you find out later on it was never MS, it was actually MOGAD. And I say that to a lot of people because we have a lot of atypical MS sometimes, and we still don't know everything. And there may be more antibodies that we have yet to discover that we can show, oh, this is clinically distinct. And it also highlights the importance of being on the appropriate treatment. Even if you don't have the exact perfect label for what's going on with you, if there's some sort of relapsing or progressive disease, what's most important is to stop the relapses and stop the progression. This is a busy slide. I've only put it in here just to highlight a couple things. So these are the criteria we use to diagnose NMOSD. And if you have that positive antibody test, the diagnosis is very straightforward. You had a symptom of any of these core clinical characteristics, which we've already discussed today, and you have a positive test, that's it. Where we get into some difficulty is if you have seronegative NMOSD, meaning you did not test positive for that antibody. That happens in about 15 to 20% of NMOSD cases. They don't have that positive antibody test. And when that happens, you have to start checking off all these boxes for different kind of criteria, and certain MRI conditions have to be met. And it makes it really hard to feel confident in your diagnosis at times. So this is a little bit of a diagnostic dilemma. So we want to make sure that we are diagnosing NMOSD appropriately, because some immune therapies can worsen NMOSD. There are certain MS treatments that are used that can make NMOSD worse. The other thing is that we have to be diligent about repeating that antibody test in someone that we have a high clinical suspicion for with NMOSD, because sometimes it's negative, especially if maybe there were some immune therapies given early on. But to keep looking if you think that's what's going on. What we don't have right now is a protocol or a plan for how often and how long should you repeat that testing. And probably I'd argue that one of the larger problems is that we don't have any FDA-approved treatments for seronegative NMOSD. And it does make sense, unfortunately, because you're saying you're already starting off with a rare disease and then taking a very small subset of that, again, that 15% or so, and we don't have enough patients to study the drug adequately in clinical trials. And then when it's not FDA approved, as you can imagine, it's very difficult to get drug for those individuals covered by insurance. So again, why is early diagnosis of NMOSD critical? We know there's high risk of relapse and there's high risk of disability. It's an attack-driven disease, and we want to shut it down as early as we can. We know there's very poor post-relapse recovery. And thirdly, we want to avoid inappropriate treatment. I'll also add a fourth one, is that we know, because there is that high risk of relapse and disability, that by prolonging that diagnosis, you're utilizing all these healthcare, hospitalizations, doctor's visits, all of these things that could otherwise be avoided with an accurate diagnosis early on. As it stands now, the rate of misdiagnosis in NMOSD is 30 to 40%. Again, the majority of those patients are diagnosed with MS. So there was a study to look at what factors are present that make it more likely to have that misdiagnosis early on. And one of those was atypical presenting symptoms. So for example, if your first presenting symptom is that upset, nausea, vomiting, that was associated with a higher rate of misdiagnosis. Also, the time to MRI, the longer it took to get that first MRI scanner, the more likely you were to be misdiagnosed. The time to see an MS or neuroimmunologist specialist, also associated with higher rate of misdiagnosis. And then lastly, the time to antibody testing, getting that antibody test to look for that AQP4, also associated with it. So those some of those are under our control and some aren't, right? But getting an MRI quickly, getting to a specialist quickly, and getting that MRI quickly are all things that we really try to push for and advocate for. This is the MOGAD criteria. Again, these just came out last year, very new. I brought it up because, again, similar to NMOSD, it's got some weirdness going on. If you have a symptom to go along with MOGAD and you have a positive antibody titer of a certain level, easy peasy, you have your diagnosis. But if you have a negative, if you have a titer, so with MOGAD, the difference, one of the, again, quirks here are a lot of people will test positive for this antibody and not have symptoms, or they may have a very low titer, so less than 1 to 100. And we have to ask ourselves, how clinically meaningful is that? So it gets a little confusing. So when someone has that low titer, they have to meet additional criteria. There are patients that I have with MS that I know is MS that have positive antibody tests for MOGAD, but they're very low and it doesn't look like MOGAD. So they're treated like MS. And so this really highlights too, being followed by somebody that is familiar enough to kind of make those decisions, because it can be very difficult at times. So here we're going to talk about the treatments that we have available. For NMOSD, there are 4 FDA-approved treatments now. The first one came to market in 2019, so that's just 5 years ago. Previous to that coming to market, all treatments were off-label. Vast majority of patients, I would say, were on rituximab. And I'll go over the FDA-approved treatments in a little bit, but they're fairly new. For MOGAD, we don't have any FDA-approved treatments, so everything we use for MOGAD is considered off-label. But the good news is that there are currently 2 drugs that are in phase 3 clinical trials that we are hoping will come to market in the next couple years. Okay, so these are FDA-approved treatments for NMOSD. The first 2, so eculizumab, the brand name is Solaris, and I coupled that with the one that just came out most recently for NMOSD, that's ravulizumab. Ultomiris is the brand name. They both work the same. That's why I coupled them together. They are both IV infusions. The first one, eculizumab, is given every 2 weeks, whereas the newer one that just came out, every 8 weeks. That's the primary difference between them, is just the timing of the infusions. The one caveat with that particular medicine is that the mechanism of action, it's what we call a complement 5 inhibitor, and that molecule is really involved in like an inflammatory cascade that we think drives disease in NMOSD. But with inhibiting that, it does put the person at higher risk for certain types of bacterial infections. And so before being on those treatments, you need to be vaccinated against meningococcal vaccine. Sometimes the person cannot be vaccinated in time, in which case your doctor will probably put you on preventive treatment until you can get the vaccination. The next one I want to talk about is inebilizumab. The brand name there is Uplizna. This works against CD19. It's a CD19 monoclonal antibody. And just for, again, reference sake, rituximab is a CD20 monoclonal antibody. So they both work against B cells. They deplete B cells. There are definitely some differences from CD19 and CD20, so it's not the same drug, but it's given similarly. It's an IV infusion, and it's every 6 months. And then the fourth one I want to talk about is satralizumab. It goes by the brand name of Enspryng. And this is an IL-6 inhibitor. And IL-6 is an interleukin that, again, promotes inflammation. So by inhibiting it, you're lessening that inflammation that's thought to be involved in the disease manifestation. This is a subcutaneous injection that's given once a month. So again, we have 4 treatments now over the past 5 years, whereas before that, we did not have any FDA-approved treatments. All right, and then to kind of wrap up the end of the talk, we're just going to talk some about the optic issues that we see with all 3, MS, NMOSD, and MOGAD. All right, so optic neuritis. And I have a picture of the optic nerve here. So again, this part, and it goes all the way back here. So this is the front of the optic nerve, and then you kind of have the back here. So front and back. And so that inflammation can happen anywhere along the path of that nerve. Sometimes it's really subtle to tell. This is an MRI. This is what we look at when we're looking for optic neuritis. And basically you're just looking for it to be that white means it's more inflamed than that side. So this side right here is the side with the optic nerve inflammation. And the other thing I'll mention also is that, we're talking about optic neuritis, and MS and NMOSD and MOGAD, but people can have optic neuritis from a whole lot of things. It's the differential diagnosis is huge. There's a post-infectious, there's other autoimmune causes. And so optic neuritis by itself doesn't just belong to these three diagnoses, but I think we're really moving to a point that if someone has optic neuritis, you at least need to consider these three. So what do we talk about when the optic neuritis first happens? And what we usually, it varies, but we typically see the onset of the symptoms over hours to days, and it kind of peaks after a week or two. But eye pain, over 90% of people with optic neuritis will have eye pain, and it's because that optic nerve is swollen. So when you move your eyeball, it's kind of pulling a little bit. So it's eye pain with movement. We also can see an afferent pupillary defect. So for those of you with optic neuritis, or just when you go to see your doctor, when we're flashing that bright light in your eyes and going back and forth, what are we looking for? We're looking to make sure that that pupil is responding to light appropriately. The appropriate thing when the bright light is in your eye is for the pupil to constrict. And sometimes if that light is not being received appropriately because of optic neuritis, we're shining that light in there and it's not really restricting appropriately. Okay, so that's what we mean by the afferent pupillary defect. Central scotoma, we typically see, and that's going to be like that black spot right in the middle of the vision, black or gray, so that obscured vision. Photopsias, so that is flickering lights. Maybe it looks like tinsel flashes that are just kind of in the vision. That could go along with the optic neuritis as well. We see that maybe about a third of the time. Loss of color vision acutely, especially red. A lot of people, it's the red looks less red when they have that optic neuritis. And then papillitis. That is, again, if the optic nerve inflammation is happening, let me go back. Closer to this part here where the optic nerve meets the eyeball, when they look at the back of the eye, they can see the inflammation there. So what about chronic features? And what do I mean by that? So acute features mean the inflammation is there, it's active, everything's kind of new. The inflammation eventually goes away, but it leaves behind some scarring. And the degree of that scarring varies, right? So you can have persistent visual loss, or you could have no visual loss at all. It just depends on how it recovered. And so as we see with MS and MOGAD, there tends to be a better recovery. You're less likely to have persistent visual loss, especially early on in the disease course for multiple sclerosis. Versus NMOSD with optic neuritis there, we tend to see some degree of persistent visual loss. Light sensitivity can continue in the long term. A lot of patients will complain of, especially driving at night, when you're dealing with darkness and then there's like oncoming traffic. So you see lights and now your eyes are having to hurry up and adjust between like light and dark, and it doesn't want to do it quickly. It makes night driving very difficult. Color desaturation, similar to the acute findings where colors aren't looking as vibrant as before. Uthoff phenomenon. This is common. So this is where you have worsening or recurrence of vision changes if you become overheated, if you've got a fever, if you, anything that kind of brings that body temperature, a hot shower, a hot tub, you may notice that the vision is getting a little blurry, or some of those old symptoms are a little bit more pronounced. And it's just a phenomenon. It doesn't mean the inflammation is back. It's just what happens when the body temperature goes up. And then optic atrophy. So that is when, again, some of you may have been told this who have had optic neuritis, is that when you go to the eye doctor and they say that your optic disc looks different, and they could tell maybe you've had optic neuritis in the past, and because once it is no longer active and inflamed, it tends to scar down and look a little smaller. And that's how they can, again, you tell between a brand new or acute optic neuritis versus something that maybe happened a long time ago. So just to compare those three with optic neuritis, there is a variable clinical presentation. So we tend to see bilateral more often with NMOSD and MOGAD. The MS and MOGAD tend to have a little bit less residual impairment and a better recovery, with NMOSD tends to have a poorer recovery. And then relapsing versus single episode. With MOGAD, it can be an isolated event. So what about double vision? Double vision is another not uncommon optic issue that can happen in these three diseases. So diplopia means seeing, or double vision means seeing two images instead of a single image. And it's caused by misalignment of the eyes. So rather than being able to maintain focus appropriately, one is a little off. And so the images are separating. And for what we're looking at, we call it binocular diplopia. And you could always do this test if you're seeing two things. You want to know if it's monocular, meaning one eye, or binocular, two eyes. You cover one eye. And if the double vision goes away, you know it's because the two eyes are misaligned. If you cover one eye and the double vision is still there, that's an eyeball problem. It's not coming from the brain or how the eyes are being controlled. So when you have double vision, where does it come from? So again, there are nerves that control how the muscles of the eye move. And if one of those nerves is damaged, it's not going to control it correctly. And then you're going to get, and these are the muscles here, you're going to get that double vision. And so again, it comes from the brain, oftentimes where those nerves that control eye movements are originating. And then internuclear ophthalmoplegia. Have y'all heard of that before? INOs, we kind of throw that term around sometimes. This is, we always say that no particular symptom is like belongs to any particular diagnosis, but whenever we see an INO, we definitely tend to think about multiple sclerosis when it's isolated. But it can happen with any of those conditions. It can happen with other non-autoimmune conditions too, like stroke and that sort of thing. But it is something we don't see, it's not infrequent to see this in our MS clinics. There's a part of your brain that controls moving your eyes from side to side. We call it the lateral gaze center. And when it doesn't, if there's a lesion there, it creates a very interesting pattern where if you're trying to look in one direction, one eye might move, but it works fine looking in the other direction. And it never, I'm not going to say never, it's rare that it looks as dramatic as this. It's more something we see looking from side to side where one eye is just lagging a little bit and you could catch up. And so dealing with that, it may be that if you're trying to look from one person to another, there's like half a second where the images aren't together, and then it kind of comes together after a while because that lagging eye needed to catch up. And then lastly is nystagmus. So nystagmus is involuntary, repetitive, rapid movements of the eye. And what I'm talking about today is talking about central nystagmus. Much more common than central nystagmus is peripheral. So if you could have an ear infection or something going on in the inner ear, and that can give you some brief nystagmus. And so again, this does not belong to these types of disorders that I'm talking about. But when it's coming from the brain, it gives you this central nystagmus pattern, and it can look differently. The movements, the eyeballs can be shaking up and down. They can go side to side, and they can be rotary or torsional. And when it happens, it's incredibly difficult to treat. So anyone that's living with nystagmus can attest to that. The medications, there are ones that we can try, but they rarely ever result in complete relief of those eye movements. And that is the majority of my talk. So I listed some resources for rare disease, NMOSD and MOGAD. They're listed here. And that was, I have a thank you slide, but I'll leave that up there in case anyone takes pictures.
Okay, we're going to do questions.
Okay, so Dr. Rosenthal, so with the nystagmus, it said that it's difficult to treat, but can it be treated at all?
Right. So there are medicines that we try. Can't think of a case where I started the treatment and then nystagmus got completely better. More often than not, it doesn't do anything, doesn't help at all, or it limits it a little bit. And what we also want to do is we want to be careful not to create new problems by putting someone on a treatment where maybe the nystagmus is a little better, but now they feel like crap because of the side effects from the medicine. So, and that's what I mean, because, if it helps a little bit, you're like, well, let's increase the dose and let's increase it and let's increase it. And we don't want to do that. So it is a hard symptom to treat, but there are things to certainly try.
Yeah, so I got a question. I have really bad environmental allergies, and before I was diagnosed with multiple sclerosis, I've been on shots for like 5 years. I
Next
started,
question.
I started taking DMTs,
Mm-hmm.
and then I'm having all these symptoms I haven't had in 5 years. They're popping back up. So just like recently, they think it's a virus. They don't think it's my allergies been sick, but I've been having a virus for the last 3 months. But he can't figure out what's going on. But it's
Mhm.
also making my MS symptoms awful,
Mhm.
and everything is flaring up. Basically, have you ever heard of cases like that before?
So part of it makes sense to me and part of it doesn't. So I think it makes perfect sense that when you're dealing with infection and not feeling well, the MS symptoms are kind of be more pronounced. Things flaring up with also taking the immune therapy, that's the part where I can't, it's difficult for me to make a direct link there. Doesn't mean it's not there. It just means I'm not sure of it. It's not something I've heard of before. Yeah.
So, in listening to you, you said inflammatory cascade drives disease. And what I was noticing was that with the complement inhibitor, that is true with NMOSD and also with myasthenia gravis. And I noticed also a crossover of some of the treatments to a lot of other conditions. So I know you're not talking about MG today, but I just found it very interesting that a lot of the things that are used to treat these other conditions also work well for people with MG.
Absolutely. So, and they share that, right? Those two disease processes. And I think it also highlights, because there's a lot of overlap between these and a whole lot of other just autoimmune diseases in general. Like if you just look at all the things you could use rituximab for, it's a lot. It's a lot of things you could use it for. And that highlights the importance of not, getting so, I'll put it this way. It's not, we don't really necessarily confuse NMOSD and MG, but let's say for argument's sake, we did. And we're like, I don't know which it is. At some point you're like, it doesn't matter. Put them on the drug that we know would cover both of them. Yeah.
So knowing that there's this problem with inflammation, would you recommend that people with any of these diagnoses subscribe to more of an anti-inflammatory diet or AIP protocol?
That is a very difficult question to answer. And part of it is because it's very hard to do controlled trials on diet and then measure the outcome. There's a lot of data out there, right? That just hasn't been as rigorously tested as we'd like to. My personal feelings are that the diet stuff is very individualized. So I think for some people, it probably makes a difference. And for some people, it may make no difference at all. But what we don't, I have no way to predict which category you're in. And then let's say it does make a difference. Does that mean you need to avoid all pro-inflammatory foods, or is just dairy the bad guy for you? Or is it just animal fats or something? So I think it's varies. I oftentimes recommend, if that's something anybody wants to explore, to rather than just kind of take a approach where you kick everything out, to do one thing at a time and do it very slowly, 2, 3, 4, 5 months, see if you feel better, and then measure it like that. Do one thing at a time, because if it doesn't make a difference, why live without cheese and ice cream,
Hi, Dr. Rosenthal. Thank you again. And I just wanted to ask you about the enigma that when you have things happen to you and you feel like there's an emergency. You mentioned this before, but they look in the x-ray and it doesn't show that there's new lesions or stuff like that. I noticed that happening a lot, and I was just wondering, is there a name for that? Is there a way we can convey that to, our doctors or to like an emergency room personnel, about that?
So I guess there's not one answer for that. For anybody that is living with any sort of central nervous system insult, whether it be MS, stroke, NMOSD, MOGAD, there are certain things that can give you what we call a pseudo relapse or a pseudo flare. That's probably the most common reason for someone to have an abrupt change that is not due to new inflammation somewhere. I prefer it actually when the ER, if someone's going to the ER, if they'll like reach out, because I can give them a little bit more context. Because sometimes if they know you have a history of MS, for example, they'll just say, oh, you just need some steroids. And then maybe that's all you get. And, there are cases where infections have been missed, and that was what was at the root of the actual problem. So if I have somebody, with any of these conditions, and you were to call in and say, I think I'm having a flare, and there's no new disease, I'm like, well, something's going on to where your body isn't compensating as well. We need to figure it out. The other thing you were asking a little bit, where we talk about kind of that progression, but there's not a relapse, that's less of an acute issue. Usually it's not something that just kind of shows up abruptly. It's a very slow kind of decline in process that we're still trying to figure out. A lot of our patients are doing so well and living normal lengths of lives and that sort of thing. And so we're focusing a lot on how these symptoms are in the aging population, because naturally, whether you are living with one of these diagnoses or not, there is going to be some progression. People slow down, the thought processes change, reflexes and postural reflexes aren't as strong. So these things happen. So what's the combination of that with having lesions in your central nervous system? How does that interact? How does that play out? So there's still a lot to figure out there.
My question is, so a blood test would normally pick up if there is an infection, wouldn't it?
Yeah. Well, it depends what kind of infection you're looking for. So sometimes it can, you may not pick it up if you have like a pneumonia or a bronchitis or a sinus infection. The blood test will pick it up if the infection is spread to the blood, or if you're having a systemic reaction to the blood test, but it doesn't always pick it up. We see a lot of urinary tract infections in our patients. We see a lot of lung infections in our patients. So sometimes when we're not sure, we usually want to get labs, look at your urine, look at the chest. Let's just kind of make sure there's nothing going on. Especially wounds is another one. If someone has wounds from immobility, that can be a source of infection as well.
So follow up what Miss Amber was saying. Doctors are saying, okay, everything is perfectly normal, but you notice that your body is changing. And, things are getting worse. Things are harder for you to do. But you have doctors that are saying, okay, well, it's normal. What is your advice on this, to talk to your doctors about all these new symptoms? But they're saying, oh, you'll be okay. It's normal. And they just give you steroids, but steroids are not working.
My advice to a patient with that problem would be to be direct in what you need. If all you want is an explanation for why it's happening, well, then it may be that it is this kind of progression or not, and that may be the end of it. But if you're wanting treatment for it, that would make that clear. I don't necessarily need an answer for what's causing it. You may or may not have that answer, but at the end of the day, I have this pain or I have this issue, and what can we do to make that issue better? Okay, the only reason really with any of these conditions that you would need steroids is if you're having a new attack. That's what we use the steroids for. When you're in the middle of a new attack, when you're dealing with old symptoms, really steroids aren't indicated. You treat the symptom for what it is.
I took a picture of some of your slides that I had questions on, and one of them was the slide that you presented that had the NMOSD with the female to male ratio at 9:1. I'm noticing that a lot of autoimmune conditions seem to affect more women.
All of them, most of them, yeah.
That's
everything from lupus to rheumatoid arthritis. Autoimmune conditions, generally speaking, tend to affect women more than men.
Any thoughts on why that is?
I don't know, actually. There's got to be a reason for why. I'm not, maybe, I don't know if it's something hormonal or not, but I think that's one of those things I never really questioned, but I think I just accepted because for as long as time has been, autoimmune conditions tend to affect women more than men.
First, I kept thinking, well, maybe it's because more women go to the doctor more often, and so they're finding it more.
I don't think it's that one.
Okay.
Yeah. I'm going to hope that it's actually something biologic and not behavioral.
And then the other was in terms of the ethnicity, why is it that Black and Asian people have more diagnosis of NMOSD?
Yeah, so it comes down to genetics. Your genes, you have different genetic variations that are more that lend itself more to certain disease processes. You know, even if you look at MS, I'll go back to MS because we obviously know a bit more about it compared to the other ones. But you'll see certain groups and ethnic populations that are more likely to have certain genetic variations that lend itself to different risks. So if you even look at from a race standpoint with MS, if you look at people from Africa versus those in Black people in America, we have a certain amount of European ancestry that also is going to give us a different risk because there's probably one of the more stronger genetic variations for MS across the board is associated with European ancestry, but you don't necessarily have to look European to have that genetic variation. So it gets that part of it gets very complicated. But yeah, the Asian and African ancestry has certain genetic variations that just put people at higher risk for it.
On the 9-to-1 female to male ratio, do you know if they've broken down the female side into those that have given birth versus not?
They may have that data may be out there. I'm not sure of it. Yeah, I'm not sure of what it would. I was going to guess that majority probably have given birth just based on the age of the more common age of onset. But I'd have to do some digging to see if that was a pattern they were able to find. It's really hard with rare disease too to try to get patterns because we need more patients. We don't want more patients, but we would need more patients to make conclusions.
When you say pseudo-reoccurrences, can you break that down a little bit for me?
When I say pseudo?
Pseudo-reoccurrence.
Pseudo. So that means that it looks like a relapse.
But it's not. Really.
But it's not. So when we say relapse, what I get worried about is there a new lesion somewhere that's causing inflammation that shouldn't be there? Because when I have somebody on MS treatment or NMOSD or MOGAD, I don't want new symptoms. There shouldn't be new lesions coming up anymore. The whole point of these treatments are to shut it down completely. So sometimes if something happens, and it could be that you overexerted yourself, you got too hot, you had a fever, anything that sets your baseline off makes it so sometimes you can't compensate for those symptoms you may have been compensating well before, and now they're more present. And typically they're going to be old symptoms that you've had before that are either recurring or worse. A pseudo relapse or a pseudo flare, it shouldn't be a new symptom you've never had before. It'd be old symptoms that now are bothering you a bit more. And it's temporary. Once you feel better from whatever thing put you off, they go away.
Hi, I'm over here.
It's bright lights.
I know you mentioned ethnicity and different ethnic cultures are more susceptible for whatever reason. But do you know if any research has been done on genes as far as like family genes, like a family may have more or less autoimmune illnesses within that family?
So there is research on that, and they're definitely trying to get more people to do these family studies. But we see that. So NMOSD, I want to say maybe 3% is familial. It's very uncommon. I personally don't have anybody that I follow with NMOSD that has a family member with it, but it can happen. With MS, there too is a familial component. They say it's, the child, first, a little bit, 3 to 5% a child for someone that has a parent with MS. But it varies a lot. So most of my MS patients don't have a family member with MS. They may have a family member with other autoimmune disease. But then every once in a while, I have someone come in and everybody's got MS. Mom has it, brothers have it, cousins have it. Clearly something is going on with their genetics that's different from other people. So whatever gene or genetic variation they have has a stronger, what we call penetrance. It's, you have it and you're more likely to manifest that disease. Now, can I tell you what those are? No, but we need those families to go in and have full genetic testing so we can try and discover that. I'm not sure if the study is still in. Last time I looked it up, which is probably maybe 6 or 9 months ago, they were still looking at that. But there are studies where you can, and your family members can donate blood. You don't have to go in person. You can send it through the mail and they can try to look into those sorts of things because that is a big area of research.
You'd mentioned earlier that if there's just no attacks, there's no progression going on. Have you seen in anybody where they haven't had any new attacks, no new lesions or anything going on, but still existing symptoms are getting worse?
Yes. And so, and I'll put a caveat with that because with NMOSD, you can have progression in between. And we're still learning a lot about these, but it's not necessarily because of, as much behind the scenes stuff happening as we see with multiple sclerosis. But if you take somebody who, went from walking to now is wheelchair bound, you're going to have progression in the sense of there's going to be muscle atrophy because you're not using the muscles anymore. You're going to have spasticity and other things that can progress as a result of those initial attacks. So it's not always a straight line in between.
I'm Marvin Sparks. Don't no one in my family on neither side have MS.
Mm-hmm.
And it's hard for me to, accept that, but I don't know, but because I ain't got no choice but to accept it.
Mm-hmm.
But and then a lot of people don't know about it. And then like, for instance, I'm gonna give you a example. Like my dad almost 80 years old, so he be expecting me to do the things I used to do, but I can't. And I can't move the way I used to, and I guess he don't understand that because a person don't have that, haven't read up on any of that. They don't understand none of that.
Yeah. So it's unfair when you're living with something like this and you feel like you have to educate all the people around you on all the things that it can do. And then not only the outward manifestations, but kind of those invisible symptoms too that prevent you from doing certain things. And there's not a perfect answer for it. I always try to tell my patients if there's someone that just really isn't grasping it or maybe thinks you're just kind of embellishing, bring them to the appointment and they can kind of listen to all the things that we're talking about, my concerns, and it kind of helps to have someone else reiterate that.
I'm just a little curious as I have MS. I have a first cousin that has neuromyelitis optica and another first cousin that has Parkinson's. We're all on my dad's side. So I'm just wondering
Yeah. So dad's side has more is more prone to autoimmune disease, and that's kind of how I would look at it. So when I see a new patient and I'm taking that family history, I do ask, does anybody else in the family have MS? But I'm also asking about psoriasis, Crohn's disease, lupus, rheumatoid arthritis, thyroid disease, type 1. I'm asking about all types of autoimmune disease because what we find is that it's not always the same one. It's different ones falling under that autoimmune disease umbrella. Yeah, it will. Absolutely.
Hi, Dr. Rosenthal. Okay, you just said psoriasis. My sister has psoriasis. I have MS. So there's a connection?
From an autoimmune disease standpoint, and it's in family members, and then even people living with MS, you're more likely to have other autoimmune diseases too. So we see a lot of people with more than one.
Well, let's thank the doctor and thank everybody for presenting. And thank you guys for Alexion for supporting the program. And this has been an MS Views and News program. Have a good day, guys.